Okay, welcome to the Rise Up webinar series hosted by Hydrocephalus Canada and Association de Spina-bifida et de Hydrocéphalie du Québec. I'm Shauna Bodway, Director of Programs and Information for Hydrocephalus Canada, Lawrence Lessier, Executive Director, and Margot, I'm not going to be able to say your last name, Margot. She is the Mobilization and Events Coordinator of Association de Spina-bifida et de Hydrocephalus du Québec, who are also with us today. This collaborative webinar aims to overcome the language barriers of our two communities and gives French and English-speaking Canadians the opportunity to access up-to-date information and benefit from the expertise of health specialists in the care of people with spina bifida and hydrocephalus. Today's event will be recorded for future access, available on both organizations' YouTube channels. Participants' cameras and speakers will not be available during the webinar. To submit questions, please use the chat feature or email info@hydrocephalus.ca or info@spina.qc.ca. This is a bilingual event. Please ensure you have selected the correct language to view this webinar in the chat feature. To do so, click on the interpretation image. It looks like a little globe down at the bottom of your page or your screen, and select your preferred language of English or French to be on the right channel. Okay. Do you want to wait a few more minutes before you start, Dr. Berndl, or do you want to go ahead?
It's up to you. If you wanted to give it a few more moments so that people can log on, that's great. Otherwise, okay. I'm happy to start now.
Okay, I'll continue with the introduction and then we'll start. Today, we are very excited and honored to have Dr. Anne Berndl, a maternal fetal medicine specialist at Sunnybrook Hospital in Toronto, with us for this presentation. Dr. Berndl is an assistant professor at the University of Toronto and an associate scientist at the Sunnybrook Research Institute. She is the director of the Accessible Care Pregnancy Clinic, the first clinic in North America to provide pregnancy care and pregnancy care specifically for women with physical disabilities. Her research focuses on physical disability in pregnancy, as well as cervical ripening methods. Today, Dr. Berndl will be discussing health issues for girls and women with spina bifida, focusing on pregnancy and childbirth and highlighting the recently published Women's Health Guidelines for people with spina bifida and hydrocephalus. Welcome, Dr. Berndl.
Thank you so much. I'm really excited to be presenting, and I'm really excited that we're able to do this in 2 languages as well. So I'm just going to talk a little bit about the goals of the presentation for today. So I'm going to talk a little bit about the need for guidelines in the field of pregnancy and spina bifida and how they were developed. I'm going to talk about these guidelines in a consumer-focused manner. And I realize that we have a mixed group in terms of people who are attending today. So we have some people who are care providers or have a medical background. And then we also have a number of people who have spina bifida and have questions about pregnancy and spina bifida. So I'm going to try to present it in a way that's relevant for all people who are attending. At the end of the presentation, I want to talk about some resources that are available, both for people with spina bifida who are considering a pregnancy, as well as the clinicians who are caring for those individuals. So these guidelines for the care of people with spina bifida was developed with the Spina Bifida Association, which is an American group that focuses on spina bifida. I want to talk about why we needed to do this. So healthcare providers, we know from a number of different papers, may not be trained specifically to care for women with physical disabilities. So there is this gap that's there. There also has been some documentation that healthcare providers can lack confidence in caring for pregnant people with physical disabilities, which makes sense if they don't have the training to feel confident to do that. When we do guidelines, we can improve a standardized approach. So that means that people, regardless of where they're living, that they're more likely to get a similar approach to care, and so to get more even care. And it also lets clinicians and researchers know where there's gaps in the literature. So where should we be putting more efforts in terms of learning more to make sure we can provide good care? Something that I think is really reassuring and exciting is that we've done other research and we found that clinicians want to learn more and become better at caring for people with physical disabilities during pregnancy. And this is based on data from residents in obstetrics and gynecology in Canada, that there really is a desire to learn more. So we're hoping that with improved curriculum, there'll be just more well-trained clinicians who can care for people with spina bifida during their pregnancies. The important thing about people with spina bifida is that spina bifida, of course, has a number of specific health concerns, and they're really quite vary from individual to individual with spina bifida. But these health concerns can impact pregnancy from the preconception timeframe all the way to delivery and in the postpartum as well. An important thing to know is that more people with spina bifida are having babies. So this is some data from Quebec showing that there's an increase in people who are mothers with spina bifida giving birth. And in terms of looking at this graph, the black line is the number, and the two dotted lines are the 95th centile around that. So in terms of developing these guidelines, this was done with support for the Center for Disease Control and Prevention and the Spina Bifida Association together. It was first put out as a series of guidelines in 2003, and this current iteration is the 4th revision. It took a very long time. It was a very, very big project. We did 3 years of planning. We had a number of meetings, literature review. And something that I think was really important about this is that there were consumer representatives that were an important part of this development, meaning individuals with spina bifida were reviewing the clinical questions that we were asking to make sure that they were questions that were relevant to the lives of people with spina bifida. So these are the authors on the guidelines. So myself, Dr. Margaret Nosek, and Dr. Ashley Waddington. This was a huge guideline. There were 58 different recommendations that were made, and it looked throughout the lifespan. However, today, because I'm an obstetrician, I'm going to be talking about antenatal care, which means prenatal care, care surrounding birth, and breastfeeding. So the most important part when you're thinking about becoming pregnancy is the planning itself. And I recommend that if you're an individual with spina bifida and considering pregnancy, that you have a preconception consultation. And the people that you should probably be talking to is either a maternal fetal medicine specialist or an obstetrician who's in your area. And many people may also find it beneficial to speak to their neurologist or their urologist or their physiatrist, depending on what health concerns you have beforehand, to make sure that you're in optimal health when you enter pregnancy. And preconception consultation has been found to be beneficial for people who have a number of different health concerns, just to make sure that you're in your best health as possible when you're starting your pregnancy. The other thing that's important for people with spina bifida is they start supplementing with folic acid, 4 to 5 milligrams a day, 3 months prior to conception. And you'll see that it's the 4 to 5 milligrams, and they're both okay to do. And that just depends on the formulation that you're taking. So spina bifida and pregnancy, there's a lot of impacts that pregnancy can have on the bodies of people with spina bifida. And again, the thing that I want to reiterate is just how varied the health of people with spina bifida is, and how it can change through their lifespan, and also how everyone's going to have different aspects of their health that they're more concerned about. But when you're thinking about pregnancy, some of the major issues that we might be talking about to make sure that you're in optimal health are concerning your breathing, changes in mobility or pain, bowel changes, your bladder and kidney health, concerns surrounding the shunt, and increased seizure frequency. So these are some big things to talk about and think about during pregnancy. So from a respiratory change perspective, we do know that people who use wheelchairs routinely, as well as people who have scoliosis, may have changes in breathing during pregnancy. And this can be associated with a restricted space. So this doesn't mean it's going to happen to everyone, but there is an increased chance of this happening. We also know that some people who have significant restriction of their breathing can impact the timing and mode of delivery for those individuals. So the recommendation is that we do some pulmonary function testing at least once during pregnancy for individuals who use their wheelchair routinely or have scoliosis. In the clinic that I run in conjunction with the respirologist that I work with, we've decided that we'll do screening at around 28 weeks, which is as we enter into the third trimester. But if there's any concerns before that, then of course we would do the screening earlier. Changes in mobility and pain. So a number of people do experience these changes. And some people need to be changing the type of mobility device or supportive device that they're using during their pregnancy, or have to have their wheelchair refit. So for example, this might mean that someone who is using a brace may also use a cane during the pregnancy for extra support. We might have someone who chooses to go from using canes to using a scooter, for example, for distances. It's really to just make sure that people are feeling comfortable. It can help with pain for some people, and it's an important part of fall reduction. So during pregnancy, it's normal that joints become looser, and that's just some of the hormonal changes that are there, and the center of gravity also shifts, and this predisposes all people to falls. If someone has weakness in a certain area or difficulty moving, then that would increase the risk of falls as well. So we're trying to help decrease the risk of falls, but also make sure that people are feeling comfortable. If people are having increased pain, some people also benefit from massage therapy or physiotherapy. Often physiotherapy is working in conjunction with occupational therapy, and that's helpful both for before and after delivery as well. In our clinic at Sunnybrook, we work with an anesthetist who specializes in chronic pain in pregnancy and can help some individuals who are having significant pain concerns. So bowel changes. Pregnancy is a time of bowel changes for everyone. The motility of your bowel slows during pregnancy. So some of the pregnancy hormones slow the rate of emptying. And so people tend to feel more bloating and experience constipation. So from the beginning, a lot of people just try some diet changes to help with constipation concerns. So, water, high fiber diet, lots of fruits and veggies can be very helpful. Some people do need more than that, and stool softeners are safe, laxatives are safe. However, some of especially the laxatives can cause like a bloating feeling or cramping, and that can be uncomfortable for some people. For people who are having significant concerns with constipation, some people may need to work with a gastroenterologist as well. So bladder and kidney concerns. Many people with spina bifida do have concerns with their bladder and kidney health. And so from a guideline perspective, it's important that clinicians are asking about ability to catheterize or what they're doing for their bladder management. And if there's concerns surrounding catheterization, it's important to work with a urologist and get them to see someone as soon as possible because there can be poor drainage as the uterus is growing. Some people also find that they have troubles with self-catheterization, especially as the uterus is growing and it just gets more and more difficult to reach and perform catheterization. One of the major worries is developing bladder infections. So in pregnancy, bladder infections don't always feel the same as bladder infections outside of pregnancy. And we know that sometimes they're asymptomatic. So we do generally try to treat asymptomatic bacteria. Because it can progress to become a bladder infection or a kidney infection as well. We know that kidney infections increase the risk of preterm birth. So it's important that we're screening and paying attention to any signs or symptoms. When we're looking at what happens to bladders during pregnancy, there's not a ton of data specific to spina bifida. Bladder changes, sometimes we need to extrapolate from some of the information on people with spinal cord injuries. When we're looking at people with spinal cord injury, it looks like many women, so 45% of people did need to change their bladder routine during pregnancy. Many people needed to increase their frequency of catheterization. And about a fifth of people had to change to using an indwelling catheter during pregnancy as well. And more than a third of people developed incontinence during pregnancy. So bladder health is a major concern during pregnancy for people with spina bifida who have bladder concerns. When we're looking at complications compared to people who don't have spinal cord injuries, which is in this data our substitute for people with spina bifida, the major worries, of course, are the infections. When we're looking at acute cystitis, which means an acute bladder infection, if you don't have a spinal cord injury, about 1 to 4% of people have one. But if you do have a spinal cord injury, then the risk is 64%. And if you have an indwelling catheter, that risk is 100%. So we're really concerned about bladder infections associated with catheterization use. There's also a greater risk of having recurrent over and over again, more than 3 of them, bladder infections. And significantly, there's an increased risk of pyelonephritis, which is a kidney infection. And for women who have paraplegia, the risk is 7%, and it's 35% in women with tetraplegia. And that's concerning not only because of the preterm birth risk, but of course, because of the discomfort associated with having a kidney infection and possibly needing to be hospitalized associated with that. Bladder management in pregnancy, there's not a ton of data, but I tried to organize some of it just to get a sense of it. There's only been one prospective trial looking at management of chronic bacteria in pregnancy in people with spinal cord injuries. And what they did was they were continually cycling different antibiotics throughout the pregnancy. And in this very small trial of only 6 people, they saw that all the babies were born at term, which is a good thing, and there were no kidney infections. So although this is really good news, I think it's really hard to say how effective this is because it's such a small group of people. In terms of the in and out catheterization, we know that there is that increased risk of bladder infections. With the indwelling catheters, about 100% of people are going to get a bladder infection, and some people also get bladder spasms. In terms of medications and treatment, oxybutynin and desmopressin are category B, which is most medications are actually in category B, which means that it appears to be safe in pregnancy, but we don't have prospective trials for it. For Botox, there's really limited evidence and is considered category C, which means you should be having a conversation about risks and benefits, but it's not necessarily absolutely contraindicated. And neuromodulators, there's really not a lot of data surrounding the use of those in pregnancy. So I'm going to shift a little bit and talk about renal function. And this is a really important aspect of pregnancy care. So ideally, before someone becomes pregnant, they'll have baseline renal assessment done. And this is because if you do have a concern with your kidney function, you need to be monitored in conjunction with nephrology during your pregnancy. And this is because renal dysfunction increases the risk of small babies, preterm delivery, and preeclampsia, which is a pregnancy-specific health concern. And there are some people who have very poor renal function at the beginning of the pregnancy, and they may have permanent deterioration of renal dysfunction following pregnancy. So it's really important to get a sense of where you're at with your renal function to help make educated choices surrounding pregnancy and monitoring. So shunts. There are cases reported of shunt obstruction during pregnancy associated with the growing uterus, but there's really different reported rates in the literature. So it's challenging to say what the rate of that occurring is. The symptoms of shunt obstruction are headaches and nausea and increased blood pressure. And this is challenging because it looks a lot like preeclampsia. If someone were to have a shunt obstruction during pregnancy, they would need multidisciplinary management, meaning discussing with the neurosurgeon as well as their obstetrician about what the right next steps are for that individual. Seizures. So ideally, if you're an individual who has seizures, you've done some preconceptual counseling and spoken to your neurologist, and you're on a single agent if possible, and as stable as possible from a seizure perspective prior to pregnancy. During pregnancy, you'll also need to be monitored by your neurologist if you are someone who has seizures, because there's an increased risk of seizures in pregnancy. And that's because your blood volume changes during pregnancy. Some people have significant nausea and vomiting during pregnancy, and so are just not able to keep some of their medications down. Sleep deprivation is really common in pregnancy, stress and anxiety, and these are things that all lower the seizure threshold. So some people do find they have an increased number of seizures in pregnancy. So I'm just going to talk a little bit now about pregnancy-specific concerns. So before I was talking more about things that might impact the health of that individual in terms of pre-existing concerns for their body and their body's function, and now talk a little bit about things that are more specific to the pregnancy itself. So in people with spina bifida, there is an increased risk of structural concerns in babies. There does appear to be an increased risk of preterm birth. And again, in people with renal dysfunction, there would be an increased risk of preeclampsia. So when I'm talking about the increased risk of structural concerns, I want to just really iterate that the choice of prenatal screening is very personal and people feel really differently about it. So you need to feel empowered to ask about having a screening or say that you're not interested in screening, depending on where you're coming from and what your choices are. But I'm going to just talk about what the options are here so that you have that knowledge. So some people choose to undergo screening because it provides them reassurance if everything is normal. There's a possible option of intrauterine therapy. So when spina bifida in a fetus is detected early on, there may be a chance for surgery that can improve the well-being of that baby after birth. And so some people want to know about that and have those choices and options. And there's also, some people find it beneficial to just have knowledge and be prepared prior to birth. It can be helpful for birth and neonatal planning. And some people might use this information to make choices surrounding continuation of the pregnancy. Some people don't want to do screening, and that's okay too. Screening for some people causes increased stress and anxiety. And if someone is having invasive testing, it can increase the risk of pregnancy loss. I'm going to go through this just briefly. And one of the reasons I wanted to talk about this is because some older literature sometimes discusses the need for invasive testing if you're screening specifically for spina bifida, but that is not currently the case. So I just wanted to make sure that people were aware that you can do that screening without anything invasive. So right now, and I'm talking from Ontario, this is what we're doing. People in different locations may have slightly different screening protocols, and that's okay too. But right now, all pregnant people, we offer a first trimester screen, which is an ultrasound plus blood work. And that's looking for different chromosomal concerns. We also offer everyone a 20-week anatomy scan. And this is a head-to-toe examination of the baby that's looking for structural concerns as well as concerns surrounding the placenta. In pregnant people with spina bifida, it would be also reasonable to offer an early anatomy scan. And that's something that we do at Sunnybrook, and a number of other centers are doing this as well. And that is being able to do the majority of the anatomy scan early on. And some people find this beneficial to know about the well-being of their baby and about any structural concerns earlier in the pregnancy rather than later. But you would still do the other aspects of the screening, the first trimester screen and the 20-week anatomy scan. If you were over 40 years old, instead of doing the first trimester screen, we would offer NIPT, which is again a non-invasive screening. And this is blood work and then the ultrasounds that would go along with that as well. And it's just more accurate for people who are over 40. Over on the other side of the chart, you'll see where it says CVS, which is chorionic villus sampling, and amniocentesis. And those are both invasive types of testing, and they're considered diagnostic for chromosomal and genetic concerns, but it's not what we're using to screen for spina bifida. So the take-home message here is that the gold standard for screening for spina bifida related structural concerns is ultrasound, so a non-invasive screening test. I'm going to move on and talk a little bit about preterm labor because it does appear that there's an increased risk of late preterm birth in people with spina bifida. So late preterm birth means preterm birth between 34 and 37 weeks of gestational age. Delivery after 37 weeks is considered term. Why do people with spina bifida have an increased risk of preterm birth? It might be related to the increased risk of bladder and kidney infections. It may be associated with an increased risk of having a Müllerian abnormalities of the uterus, meaning that some people might have a heart-shaped uterus or have sort of looks like two uteruses fused together. And those types of uteruses, people who have those types of uteruses are at greater risk of preterm birth. So we don't know the reason, but it might be because of some of those concerns. There have been some suggestions that for people with spinal cord injury, as well as people with spina bifida, have serial vaginal examinations after 28 weeks to assess for dilation, which would be a way of seeing if there appears to be a risk for preterm birth. But there's no data right now that's supporting that as a method of screening for all people. In terms of preterm labor, some people who have spina bifida might not be aware of labor contractions. So people have different degrees of sensitivity. And so sometimes it's good to talk about other ways that you may detect contractions. So some people just have abnormal pains or sensations. Some people notice a change in spasticity when they're contracting. People have bladder spasms. Depending on where the person's lesion is, they may develop autonomic dysreflexia symptoms. Some people might just notice a splash that their water has broken, and some people may have no symptoms as well. So preeclampsia, this is a pregnancy-specific condition, so it only happens when you're pregnant. And the characteristics of preeclampsia are high blood pressure. People get headaches, they get visual changes like spots in front of their eyes, they feel nauseated, they throw up, sometimes they get pain in through their upper abdomen, short of breath, and really the only treatment for this condition is delivery. We do try when people are preterm to delay delivery if it's safe to do, but sometimes it can't be. The thing that's really challenging about preeclampsia in people with spina bifida is that the symptoms are very similar to a shunt occlusion and autonomic dysreflexia. So it's really important whether you're a clinician caring for someone with spina bifida or if you're an individual with spina bifida to be aware of these things so that you can seek help and have them assessed. So we got a lot of questions, and I'm going to go into more detail about this because of these questions about mode of delivery. There is no, one size fits all mode of birth that's best for people with spina bifida. And this is really for so many reasons. And really it has to be an individualized care plan for each person, thinking through that person's health, thinking about their personal feelings and preferences, and thinking about their choices. Some of the aspects that I think are really important to discuss are anesthesia options. So it's sometimes felt that people who have spina bifida cannot have an epidural or spinal analgesia, and that's not so. So it doesn't mean that it's always possible, but it doesn't mean that it's always impossible either. So someone who has spina bifida should meet with an anesthetist beforehand and discuss what their pain control options are in labor or if there was an emergency. There's some discussion that people who have a VP shunt should have delayed pushing or no pushing. That doesn't mean you have to have a C-section if you have a shunt. We can help people who have a shunt, and if their neurologist feels they should have delayed pushing or minimal pushing, we can assist at the end with vacuum or forceps. And so that would be something to discuss with your obstetrician and your neurologist if you do have a shunt. People who have previous urological surgeries or abdominal surgeries, this can be a detailed conversation just surrounding what those surgeries were, what type of scar tissue might be there, and what would be the best case scenario for that person. Would it be better to plan for a trial of vaginal delivery and have a backup plan with a urologist available because of an increased risk of trauma to a previous urological surgery? Or would they prefer a planned cesarean section when people are not in an emergency situation where risk to damage to those structures would be less? So these are some difficult and sort of complex conversations that often require a lot of players there. But this is part of why it wouldn't be sort of a one-size-fits-all answer for people in terms of what is the right mode of delivery for them. Another important aspect is skeletal structure. So some people with spina bifida do have changes in their pelvis that might make vaginal birth more challenging. I often examine people in the third trimester if they're thinking about a vaginal delivery and they're concerned about their skeletal structure, just to assess and see if it feels like a baby's head would fit. Another key aspect is what happens in an emergency. So if there was an emergency situation, how do people feel about, for example, if they needed an emergency general anesthesia? These are some of those conversations that help to decide what the right next steps are. So postpartum, feeding the baby is one of the major things that happens afterwards. And when you have a newborn baby, they really do eat every 2 to 3 hours. So this is a major aspect of people's lives after they have their baby. The guideline statement is that we should encourage women who wish to breastfeed to do so and provide them with support from a lactation consultant. We do know from the literature that people with physical disabilities have lower rates of breastfeeding than people without physical disabilities. And it's felt that this might be multifactorial. It may be due to lack of support, people feeling quite fatigued, there's changes in healing, positioning. Some people are on medications that they're concerned about being on while breastfeeding. Sometimes it's just really challenging to get in and out of bed at night often. And so these are all things that need to be put together when deciding surrounding feeding the baby. Support is really key. So we do try to, for women who are planning on breastfeeding, to get them in touch with lactation consultants even prior to delivery. And then really creating a plan for them that works for them. And their breastfeeding goals may be no breastfeeding. It may be exclusive breastfeeding. It may be a combination of breastfeeding during the daytime hours. However, then their partner bottle feeds the baby at night because that's what makes sense most for their family. And in the end, the key is to just be supportive for that and provide with options. So in summary, there's limited information. So we need to do more research and we need to learn more so that we can provide better care. But it does appear that there's an increased risk of preterm birth. There's a risk of worsening mobility and falls. There's this clinical overlap that we really need to consider if people are presenting with high blood pressure and headaches between shunt malfunction, autonomic dysreflexia, and preeclampsia. We have to be monitoring for and treating bladder infections. And in terms of birth planning, we need to be working with a multidisciplinary team. Some of the big gaps that we discovered from doing this big review is that there's no information available on the effect of pregnancy on continence. And this is a major question for many people. There's no literature specifically on breastfeeding in the context of spina bifida. So we have information surrounding breastfeeding for women with physical disabilities, but not specifically tuned to people with spina bifida. We need more research to learn about the incidence and cause of preterm birth. So what is really driving that? And we just want to know more, and we need to know more about other pregnancy concerns such as gestational diabetes, preeclampsia, malpresentation, meaning babies being bum down instead of head down, and different postpartum complications in people with spina bifida. So we have a lot of people who have written in saying they're planning a pregnancy and what should we be doing next. So I recommend starting on the 4 to 5 milligrams of folic acid daily. Likely and preferably 3 months before you become pregnant. There is a prescription available prenatal vitamin that has 5 milligrams of folic acid. You do not need to use a prescription-based one. You can take a standard prenatal vitamin, see how much folic acid is in it, and then just take extra folic acid tablets to add up to the 4 to 5 milligrams. So that's okay to do too. If you're thinking about pregnancy, again, I can't say it enough, the preconceptual counseling can be really helpful. I put the link there for our specific clinic if you happen to be in Toronto. Otherwise, talk to your family doctor or whoever you're seeing about seeing a maternal fetal medicine specialist or a perinatologist or an obstetrician about pre-pregnancy planning. If you use seizure medications, talk to your neurologist or the person prescribing those to try to consolidate to a single medication if possible, and trying to get you in a good position for best control of your seizures. And if you have decreased kidney function, talk to your nephrologist. I put some resources here. The Center for Independent Living in Toronto has a disability and parenting network, which is really good. They also can help people organize direct funding, which is a resource where if you are someone who qualifies for an attendant in your home, then you would also qualify for a nurturing assistant, which is someone who can help with some of the physical tasks of parenting. So it's intended to assist with parenting tasks. I also put up a website of a former patient of mine. This is for only people who are parents with physical disabilities. It is not a place for clinicians. So I'm not on this Facebook group, but some people find it helpful. And she was very happy to put that up and create that as a resource for other individuals. And then the Tetra Society, which is a group that creates adaptable furniture and parenting needs for people with physical disabilities. I also put up some of the guidelines here. So the first one and the two guidelines at the top are available through the Spina-bifida Association. So one is on prenatal counseling and the other is the Women's Health Guidelines. So you can go to the Spina-bifida Association website and they're all available there. There's also, it's coming out in July, but it's available online right now through the Journal of Obstetrics and Gynecology Canada. We have a labor, delivery, and postpartum care for people with physical disabilities. And so that's a good resource as well. I'm just going to, before I take questions, because I saw so many coming through about birth, I just wanted to do a quick sort of rundown to touch base on that, because I can see this is a really important topic. This is a visual summary of what happens when people come through the accessible care pregnancy clinic. Up at the top, you can see Liz Jung, who is the advanced practice nurse that I work with, who's talking to someone on the phone. Whenever someone comes into our clinic, we touch base with them beforehand to make sure if we need any equipment to make their visit better. We have it available. We know a little bit about them, and if they have any attendants that are coming with them. We try to organize our day in conjunction with Wheel-Trans. We understand that the booking through that can be challenging. So we try to fit everything in with their Wheel-Trans appointment. After people check into our clinic, we have ultrasound at the same location as we have the clinic. So it's in just sort of parallel hallways. And our sonographers are quite experienced in scanning people with physical disabilities and sometimes scan people in the wheelchair if that's appropriate for both parties and for the type of scan that's being done. Then we create a plan of care that's personalized to that individual. So you can see there's the woman in the middle with her lovely baby, and we have a number of individuals who are just fantastic that I know I can always call upon to assist and be great referrals for people who come through the accessibility clinic. Some people need to see the respirologist, they need to see a neurologist, a pain clinician, anesthesia. Pretty much everyone has a conversation with anesthesia, urogynecology, endocrinology, hematology. So I have this group of amazing people who are really involved in the clinic and making for really great interdisciplinary care. The picture of the people around the table, I'm trying to illustrate how we all sit together and make a plan. And a key feature of what we do is in the third trimester, we all sit down together. So any of the clinicians who have been involved in the care, as well as the pregnant person and their partner, we have a big meeting all together to talk about what's going to happen around birth. And we talk about plan A and plan B, and if there's any, equipment we need to have available. And we just try to make sure that everyone's on the same page and there's really good communication from all the team members. And we've all talked about our concerns. And then we have a baby. So this is just an illustration of what happens in our ultrasound room. So here you can see a Hoyer lift off to the side, but we actually now have a ceiling lift, which is really great. And again, this is all in the same space as our clinic space. And we really want to make sure that we're prepared. We have extra long booking times. If people need them, to make sure that everyone's feeling comfortable and no one's being rushed. We try to make sure that everyone's involved. A lot of people find having their partner involved is also a really important part of the experience. These pictures were taken pre-COVID, so you'll see that many of them people are not social distancing or wearing masks. This is our accessible birthing suite, so it's really big. I'm trying to illustrate that in this picture with some of our smiling and wonderful birth unit nurses. This space is big enough to hold mobility equipment, and it also has a wheel-in washroom. So it's a good space to use. One of the key components of the care is that, regardless of which way you have a baby, it's still a birthday party, and we still want to keep the family together and involved as possible. This is a picture of someone who needed to have a general anesthesia for her birth. And you can see the gentleman off to the side wearing the black mask, and that's her partner. And we have partners come into the operating room to especially help with positioning and be there for their partner before they go to sleep. We find that having that partner there is really great, both from a person-centered care and family-centered care perspective, but partners are usually used to working with the pregnant person in terms of being comfortable and being in a comfortable position. So if we're setting someone up for a cesarean section where they might be on the table for perhaps 45 minutes or an hour, we can make sure that we've positioned them in a way that we know their body's going to be comfortable, and their partners helped us with that. I'm an obstetrician. We deliver lots of babies, so I always have to put a good birth picture in there. For people who need to be asleep during their birth, we usually will arrange for photographs or videos to be taken of their birth so that they'll have that documented for them for afterwards. And this is a particularly cute baby. We also provide breastfeeding support after delivery, but also before delivery. So many people will meet with a lactation consultant who will help them practice with weighted dolls to find comfortable positions for breastfeeding. So if there's someone who's choosing to breastfeed, we try to provide all of that support for them. And this is just some lovely pictures of people who have come through our clinic and have had lovely babies. And this is pictures of them caring for their babies, feeding their babies and snuggling their babies. And some very happy families. So thank you very much. I hope that this was informative, and I'm looking forward to your questions.
Thank you very much, Dr. Berndl. This was a very informative presentation, and we have several questions. So we're going to start by doing 3 questions in English, and then we'll switch to 3 questions from the French side. You don't have to answer in French. They will interpret it for you. So let's start with this question. Is it routine to send spina-bifida mothers for a BPP ultrasound after 34 weeks? With the concerns with maternal breathing difficulties, fetal growth restriction, would it be concerning if the movement parameter was graded as 0 if the study was limited due to those factors?
Okay, so the question I'm understanding is about monitoring, so a biophysical profile, a BPP, which is an ultrasound study. And would this be something that we would be doing routinely for people after 34 weeks in people with spina bifida? So I'll answer that piece first. So if you're looking at the general guidelines, for pregnancy monitoring, you don't necessarily have to be having an ultrasound other than 2 main ultrasounds, which would be your 12-week scan and a 20-week scan. And then if someone is going overdue, then we will do more ultrasounds as well. If someone is having breathing concerns, if there's respiratory concerns, we often would check in on the baby more frequently, as we would for a number of other health concerns. So people who have for example, if you have a kidney problem, people who are on different medications, often if you're over 40, there's a lot of different reasons why someone might have extra scans. And they're really quite great in terms of the different reasons. If someone was having respiratory concerns, I think it would make sense to check in on the baby more frequently. And if there was no movement, so if they got a 0 on that, I would myself be quite concerned about a 0 for movement on a biophysical profile, and that would need follow-up.
Okay.
That answers the question. It's hard sometimes because there's so much context that
Content,
yeah.
Exactly.
Yeah.
This next question is pretty, a lot more simple. If you use metrophen-off, how does pregnancy affect clean intermittent catheterization?
So, to be honest with that, I would probably be referring and working with the surgeon who performed the surgery for that person. I think that usually the concern is more about overall, is there going to be an obstruction with the growing uterus? But I wouldn't be able to give you information about the cleaning of it.
Okay. And my next question is, are there many spina bifida informed pregnancy clinics available in Alberta that you can recommend?
So I don't know of any in particular. However, the best resource would likely be to go and get a consultation from a maternal fetal medicine specialist. So there are people who do have more and less interest in different areas of maternal fetal medicine. And so if you ask for a referral for someone in maternal fetal medicine, it's not a huge group of people. There's probably, at this point, 120 of us in Canada. They will be able to direct you to the right person. But the major, tertiary care hospitals in Alberta would have someone who'd be able to assist you with that.
What is the reported risk of spina bifida in newborns born to moms with spina bifida?
So it depends on what the rate is that you're looking at, but it appears to be between 2 to 4%. However, if you're supplementing with the high dose folic acid beforehand, it appears to decrease that risk by about 70%.
When discussing preterm labor, being 34 to 37 weeks, this is not considered being induced, right? Along with 37 weeks plus considered term, this does not include being induced. Sorry, what are the reasons that someone would be induced?
Okay, so that the increased rate it's an increased risk of going into labor early. However, if there are other concerns, such as someone who's having significant respiratory concerns or they develop preeclampsia, those might be reasons to make a decision about delivering early. But the concern is more about preterm labor. So that would be different than being induced. So there's two different, I think that's a very good question, because there are different reasons why you might have a baby early. So one might be your body goes into labor or your water breaks, and the other is something is happening. That means that it's at that point in time, it appears safer to have the baby at that gestational age than to wait any longer. So I think that, I hope that answers that question. And then the second part of it, sorry, was about at term, do you need to be induced? Or if you wouldn't mind just repeating the second half?
Sure. I just have to find it again. I apologize. Okay. It says, along with 37 weeks plus, is this considered term, and would you be induced at that point?
So 37 weeks would be considered term. And if all else is well, then 37 weeks is usually not a time frame for induction. So again, but if someone had high blood pressure, if there are worries about the baby's well-being, if there's other concerns, then that would be considered a term induction. In terms of when should someone with spina bifida have their baby, if all else is well, they're feeling well, the baby is well, they're not having any health concerns, their blood pressure is good, then usually you can just wait for spontaneous labor. And then we would follow our standard guidelines for induction, which would be right now, we recommend an induction if you go past 41 weeks for an induction between 41 weeks and 41 weeks and 3 days. So we would just be following our standard induction guidelines.
What is the best delivery option for a woman with spina bifida, C-section or natural? I think you mentioned this in your presentation, but if you could just reiterate, that would be great.
Sure. So, and I think that's a really good question. I think it's probably a question that people ask me right at the beginning, often in their pregnancy, what should I do? And, in the end, I think we need to take into account all of those different considerations. From a health perspective, what makes best sense for them. From a control perspective, so some people feel more comfortable with one or another because to them that feels like a more controlled scenario. And to be honest, that's very different from person to person. So some people feel a vaginal delivery is a more controlled scenario, and some people feel a C-section is a more controlled scenario. And then, of course, that person's choices and feelings. So, there are some people who say, I would like a C-section for XYZ reason. And I'm happy to do that for them if they feel well informed about what that means, what recovery is like, and what the risks of the surgery are. And in the same way, if someone says, I want to trial a vaginal delivery, then I say, that's great. These are the risks and benefits of that situation as well. Often it's sort of an evolving conversation as more is learned about their pregnancy. So for example, if someone feels very uncomfortable about the idea of laboring without access to an epidural, and that might be the key piece for them about making a decision. And then if they meet with anesthesia and anesthesia says, sure, I think we can get good pain control for you during your labor, they might say, that sounds great. I like that idea. Let's go for a trial of vaginal delivery. If the idea of an emergency where they have to have an emergency intubation is the most concerning thing to that person, if, for example, they don't have access to epidural and they don't want to labor without an epidural, that person might say, I'm very uncomfortable with the idea of an emergency intubation, or I'm very worried about my previous surgeries and in an emergency scenario of having damage to that. I prefer a planned cesarean section because it makes me feel more comfortable with how my body's going to respond to that. So it's really quite an individual decision, and we take into account all of those factors: healing, their personal preferences, how they're going to feel about it, anesthesia options for them, and how it might impact their body.
Okay. I have corrected spina bifida at the age of 4 in Germany. I don't think I have a shunt, but instead a metal plate in the lower back. Would I be able to have an epidural if I were to have a natural birth?
So I think for that really specific question, I think speaking to an anesthetist would be the right thing to do, because they would be the person who would be providing that the epidural analgesia for you. And so a consultation with them, if they could examine you and talk to you about your previous surgeries, they would be able to answer that for you.
Okay. I'm going to keep going through the English questions, and then we're going to switch to French and see if we can get this figured out here. Next question. Does having spina bifida decrease any chances of becoming pregnant?
So it doesn't appear to change your fertility. Some people, if your uterus, some people with spina bifida are more likely to have what's called a Müllerian abnormality, which means instead of having a uterus that's shaped sort of like a pear, there can be pieces of the uterus that dive in and make it a heart-shaped uterus, or have a bicornuate uterus, which is like 2 horns. Or some people, they have a membrane that can hang down in the middle in the uterus. So there's many people who have this. It's not something that's unique to the spina bifida community, but people with spina bifida are just more likely to have this type of uterus than someone without spina bifida. In terms of fertility, people who have just that thin membrane down the middle, that does appear to impact fertility, because it's very challenging for the embryo to implant it if it's a very thin little membrane that's there. But otherwise, there doesn't appear to be a change in fertility.
Okay. This is from a person who has a shunt that is broken and disconnected. They have very little support and are looking for answers. Do you recommend having a baby with a broken shunt, or should they have it removed or revised before taking any actions with pregnancy?
So I think this would probably be a good idea to speak to the neurosurgeon who performed the initial surgery, or to get in contact with a new neurosurgeon to see how functioning the shunt is and what its role is playing. If it's something that is of benefit to you and you need to have it revised, it's probably better to just make sure you're in your best health before becoming pregnant. So it's not something that you need to have done during your pregnancy. But really, I think this is something that you need to speak to the neurosurgeon about how necessary and needed it is, because some people, they have a shunt and it's not functioning, but it's not impacting their life.
Okay, just looking for the next question here. We know that there is a lot of evidence on continence outcomes in spina bifida, but what is your experience with changes in continence after pregnancy?
So I think that's one of the big questions that we need to be looking more into. The hard part is that I usually only see people about 6 weeks after they deliver, where it's very common that many women still have some challenges with incontinence after delivery. And that's just the function of being an obstetrician, that I don't follow people long term in terms of what happens to their continence. I know that there are a lot of worries about that, of course, because continence is so important to quality of life. I think right now we can't say if one mode of delivery or the other is going to be changing the risk of incontinence in the future. From the urologist colleagues, right now they're not necessarily recommending that you have to have a C-section necessarily to preserve continence, unless you've had a urethral procedure. So if it's a procedure on the urethra itself, then the recommendation at this point in time is to have a C-section to preserve that, but not necessarily for other types of continence procedures. Overall, people who have vaginal deliveries are more at risk of having incontinence in the future. And overall, anyone who's been pregnant has an increased risk of incontinence in the future, just from having that baby sit on your pelvic floor for a period of time. Is it worse for people with spina bifida? I think that we don't have the data right now to know how much that changes. Would I be surprised if it was worsened by pregnancy? I wouldn't be surprised, but how long lasting is that? I don't know.
Okay, one more question. I am a prenatal and postpartum doula in Ottawa. I'm taking this presentation to be better able to assist all women and partners at their birth. Sorry, that's not for you. That's for the attendees. My apologies. I had a question regarding the indwelling catheter. Does that often cause more UTIs?
Yes. Yes. And I think it's a major challenge, because some people find that if they're doing intermittent catheterization, if it's becoming more and more challenging, or they're needing to do it more frequently, or some people just are technically finding it hard to do as their belly gets bigger and bigger, that it's a harder process. Some people decide that they do need one right at the end. But then you're sort of in a position where we're quite worried about the risk of bladder infection. So we should be screening frequently for bladder infections and paying attention to any symptoms.
Could you just highlight again why individuals with spina bifida go into labor early?
So we don't know. I think that there's speculation as that there are risk factors that appear to would make sense as to why people with spina bifida go into labor early, but we don't know yet if those are actually the reasons behind it. So it's felt that it may be associated with the increased risk of kidney infections, because we know that people with spina bifida are more likely to have kidney infections secondary to the increased risk of bladder infections, and kidney infections increase the risk of preterm birth. Also, people with spina bifida are more likely to have Müllerian abnormality, so that's change in the shape of the uterus that can predispose as well to preterm birth. So these are thoughts that it may make sense that these are reasons why people with spina bifida are more likely to have preterm birth, but we don't know yet if that is actually the reason or not. It would be good to know if that actually was the reason or not, because although we can't change the Müllerian abnormality aspect, maybe there's something we can do from the bladder infection perspective that may be an effective intervention to decrease that risk. So, right now these are thoughts that make sense, but we can't say that for sure this is the reason why people with spina bifida have preterm birth.
Okay. Thank you so much, Dr. Berndl. This has been a very interesting and informative presentation, and we will forward all of the French questions to you and get those answered. And hopefully for our next presentation, we'll get all the kinks worked out, and we'll be on track. Thank you again so very much. This is great.
Great. Thank you so much.
Okay.
Okay, take care.
Bye, everyone.